Thank you, Sharon, and good morning, everybody. And thank you, AIOS, for this opportunity. I think this is the second time this instruction course has been selected. I think Dr. Rohit helped me begin very well by stressing the importance of documentation. And I think as we go forward, we are moving towards what we would not like to call, but the reality is that of a litigious society. So we must be aware that things can go wrong, and the starting point of anything that can go right or wrong is the consent. A consent is actually a document that is protected by law, so it comes under the gamut of a medico-legal ensemble, and that is what we have to know as healthcare providers. The MCI in 2018 said that you cannot even examine or, of course, treat any patient without his or her consent, and of course we know that. But when it's in print and when it becomes part of a legal document, then it's all the more important. And it protects the autonomy of a patient, which means at the end of the day, the patient has a right to, it's their body, and we could be patients sometime, or our relatives, our parents, our children can be patients. So that's something that we must know. The law allows some rare exceptions when we don't need consent. We won't go into that too much today, but medical emergencies, when somebody is incapacitated, and we'll talk about that, what is capacity? In other words, cannot communicate, or of course has a contagious disease, something akin to what we have now, a public health risk. Consents can mainly be divided as implied or expressed. Implied is very simple. If a patient walks into your room and puts out his or her hand and says, draw my blood, or goes into a lab and is very ready to get a tourniquet tied, it's implied consent. You're not going to be putting out your hand, or you're not going to be lying down on a doctor's couch if that person didn't consent to what you wanted to do. And expressed, of course, is either oral or written. Now, it's drilled into our minds that written consent is sacrosanct, but interestingly, it's not. In fact, it's not a legal mandate to have all consents that have to be written. In other words, if you've documented a very well taken oral consent, then that stands in the court of law. And also the corollary is, just because you have a consent, it doesn't mean that it protects you from litigation. So in general, as Dr. Agarwal had written in this article, there are two types of consents, a real consent and an informed consent. We like this term informed, but it's not always necessary. And let me tell you what a real consent is. So it is something that is done when the patient has understood with adequate knowledge what the procedure is all about, has the mental soundness of making that decision, and of course it's done voluntarily. When you add layers to it, that is when you tell them the risks, the alternatives, the management of the complications, what happens if you don't get it done, then it becomes an informed consent. The Supreme Court of India, about 12, 13 years ago, said that, look, we are okay with a real consent, as long as it's documented well. But if we are moving forward to a more litigious society, commercialization of healthcare, we may be forced to take an informed consent. In other words, it's probably better for us to be prepared for the worst, but knowing at the back that if we have a real consent, it may be sufficient. So the National Law School and the Indian Medical Association says that the written word still scores over even a video consult. And of course, emergencies spoke about in their own language, and this is very, very important in our vernacular society. And the consent should be verified if you wish with a second video. So when is a consent valid? Strictly speaking, a valid consent is only these 3 points. One, it has to be done voluntarily. Second, you have to tell the patient enough information that they understand what procedure they're undergoing. And third, it has to be done by a mentally sound person. In other words, they have capacity. So this capacity definition is extremely important in the medical legal terminology. So it is in their language explaining the alternatives, being told what happens if you don't do the treatment we have recommended, and allowing sufficient time for them to assimilate this information. Now, here's an example of a LASIK consent from our institute. I'm just enlarging one portion, where in depth what Dr. Roy just spoke about, that is orthoptic problems that may not be related to refractive surgery, have been explained. And this is a side effect that that person may be already having So, jumping the gun, making sure that you've told them all the possible associations as well is one foolproof method of getting an informed consent. Now, despite telling them all that we need to, a patient is entitled to make an irrational decision. Now, that's so important. This means that they can say, look, I know that I might go blind if I don't do what you're saying, but I don't want the surgery. That is an irrational decision. As against an irrationality, if they say that I don't want surgery done because I got up from the right side of my bed, then that's irrationality. This means that they have not been explained well enough the actual effect of the surgery and why they need it. So the law makes a difference, and we have to be sure, therefore, that we engage in this dialogue. So a consent with dialogue is finally the entire process. And best thing for you to do is, when you've had this dialogue, note it down, mention it somewhere that you've had this dialogue and given them enough time to look at it. Again, here's another example of a patient undergoing refractive surgery. Look what's written right below: consent given on so-and-so date. And that's not the date of the surgery. The patient goes home with the consent, has enough time to deliberate, of course, after you've had that dialogue, and they come back, and then only it's called making an informed decision with a voluntary choice. The best form of consent you can have perhaps is, after you've explained it to them recording it in their own language, handwritten by them and signed by you and a couple of witnesses. This is really like foolproof. This shows that it's in their handwriting, they've understood it, and they've even sort of been given time to deliberate, and you can add all of those clauses inside what they write. So what are the safeguards? Mention the adverse effects, alternative treatments. Make sure if you're not giving the consent, if you're not explaining the consent as the primary surgeon, it's done by someone who's equally competent. It could be a colleague, it could be a fellow, but not a counselor or a patient care coordinator, whom finally the patient can say, look, it's somebody who didn't have that knowledge to answer my doubts, and that should not be contested at any time. And of course, give sufficient time to clarify and record this in the file, saying that you had this conversation and they had enough time, and then they came back and signed it. Here are some examples of standard template consents. I'm taking this from the Vitreoretinal Society website, which talks about giving intravitreal. And if you don't have your own consents, you can move there. And we have our own when you're taking for a minor. And when it's very important for a minor, you change the language because it's either a parent or a guardian. Theoretical constructs, literature, lacunae, talk about all the side effects, and finally, in good faith is something that we have to record, especially if it's off-label. My concluding slide is sort of summarizing what's important. Consent is a process. It's not a one-off thing. Engage in dialogue, give sufficient time, make sure that a competent authority is doing it, and make sure that the patient has understood all of that, especially in a language that is spoken or understood by them. And assume that every adult can make that choice. In a minor, of course, that's different. And despite all of that, if the patient still says no, then they are entitled to making that irrational decision. So that's all I want to say. And thank you very much for this opportunity. And thank you, Sharon, once again.